manual therapy. I might have even done reach with thumb up and then go to thumb down while I had my hands on infraspinatus or teres minor. Manual therapy. And all of a sudden he gets up and his shoulder is immaculate. All right, this one goes in the chapter of how does manual therapy work or not work. General population patient, MRI of shoulder pain. MRI is either very poorly read or just not a very impactful image. Not terribly fit, huge golf guy, shoulder only hurts in golf. Right-handed golfer, it's the back shoulder, so is there some type of way? Yeah, I think you might typically see the front shoulder on a right-handed golfer. All right. Orthopedic tests, special tests, everything is painful. Painful and breaking glenohumeral abduction, external rotation, internal rotation, thumbs down, empty can, everything boxes checked. Nothing correlates to MRI, which is good as we had it, which probably gave some modicum of confidence. Okay, we should actually try some things. And it wasn't like we weren't going to, and it's not like you shouldn't, but that could have been bad given how painful and weak he was. Remember, if we just use a Syriac's approach, non-painful weak would be a full tear, painful and weak would be partial tear, and he presented impactfully. So what did we do? And let's make sure that we bleep this out. Manual therapy. All I was doing, I started on his back, and maybe to breed some confidence, I get into subscapularis. And I'm doing it the right way, and I'm just kind of, if my hands are butting up against where his pec and ribs are, and if I can just go straight down, you kind of know you're on the subscapularis, and it's all hell. And I'm like, oh, he comes, and he could not take a lot of pressure, which is very, very telling. And you might already foresee how this works. And then get on the pec, and I'm doing my little asterisk stuff, and it is minimal. I'm literally doing nothing. I'm just rubbing on these areas. And I am kind of analyzing to see, okay, is there anywhere that's got any twitch? Is there anything that's tighter than the other? Get under the clavicle and maybe get a little bit along the pec minor. The clavicle, subclavius and pec minor will kind of be along similar positions of how you carriage the shoulder and while you treat. Even before we get to the backside, we sit up, and almost all of his tests are better. Like, hey, it's awesome, better is better. MRI is consistent, like there's not a lot going on here. My hands do not have the ability to evacuate inflammation to create some type 1 or primary or secondary compressive impingement. I do not have that ability. My hands can't change things. I can't make tendons stronger if with a few minutes of bleep this out, manual therapy. Face down. Oh my God, incredibly sensitive on teres minor. Oh my God, incredibly sensitive on infraspinatus. Actually very difficult in that position with hands to get into supraspinatus because his trap was very, very dense. But he kind of pushed the trap away and tried to, kind of hook around the spine of the scapula to get into the supraspinous fossa. All manual therapy. I might have even done reach with thumb up and then go to thumb down while I had my hands on infraspinatus or teres minor. Manual therapy. And all of a sudden he gets up and his shoulder is immaculate. His shoulder is it's almost like there was no reason for him to have come seek any type of physical therapy evaluation or treatment. So how did that happen, knowing full well that my hands doing just garbage therapy had any impact in the way it did? Well, remember I described that this is, maybe I didn't describe it well enough. Let's just say, without being insensitive, probably a very excitable individual. Let's just say he was wound really, really tight. And I think I'm actually pretty good at using language to make it clear exactly what I'm trying to say without being disrespectful for certain types of affects, if they're not conditions, that maybe people are disrespected for. This dude's wired. He's very sensitive. Just having some proper deep pressure and stimulating proprioceptors, all it was no different than holding hands or rubbing his feet or getting a back rub or something like this that actually feels good and as science would describe as a pleasant or a palliative tactile experience. That was enough to temporarily change his autonomic, because it probably has to be the autonomic nervous system, to the degree that his shoulder, which was entirely perceptive and showed up as this weak things, probably because he had been told a whole bunch of things. And I'm trying to tell him the opposite, because the MRI doesn't show any reason to have these really, really impactful primary and secondary compressive impingement symptoms. What did the therapy do? Is that what manual therapy does all the time? I'm not sure. But what I do know, and I would say this many, many times over, that I would admit, And I know, and I even told him that my manual therapy is not capable of accomplishing anything. I think other people say different. They're going to say they're breaking up adhesions. Can I just say this, by the way, when you break up an adhesion, I heard somebody else say this, they deserve the credit. If a muscle was broken up, like if a muscle goes from here to here and you broke it, that would be really bad, right? You'd probably have this big inflammatory response, it'd be painful, nothing good would happen. Why is it okay to break up scar tissue when scar tissue is what the muscle's made out of? It's just new. Like there's nothing wrong with scar tissue for one, but if you break up tissue, how is that remotely a positive thing? You're not breaking up anything. You're inputting neuroceptive input. You're changing how the brain feels. You might actually be remodeling tissue, but you're not breaking anything. Very weird to me. And I was really glad. It was a better way than I could explain it. I just say you're not breaking up anything. There's no such thing as an adhesion. But somebody had a really good way of saying you wouldn't break up a muscle. Why do you think it's okay to break up fascia? Unbelievable. I saw that too. Somebody was pushing some type of amniotic injection, which is a really, really good thing to break up fascia. Like, don't break up fascia. Like, don't break anything. Like, nothing. You don't want anything broken. But getting back to this example, knowing that my hands can't accomplish anything from a mechanical level, but maybe they can accomplish something at a neurological level, and it's just touch. And maybe that's how tape works. And maybe that's how other things that we know can't change muscle, bone, nerve, fascia, but they can change how your brain perceives things. And the uniqueness of how your brain perceives things can be centered around all sorts of different words and all different constructs that are shaped in the form of beliefs. So if he was believing that me rubbing on his pec was going to change how his shoulder moved, he was right. And that's what happened. And I am very, very clear in admitting that what I did had nothing to do with his pec and more to do with just whatever signals my hands created and his brain perceived, because there was nothing wrong with his shoulder in the first place. Will he need manual therapy again? Maybe. But I said, I don't need to see you very often. You come when you feel like you need me. Go train with my guy for as long as you can. And if you feel like you need a boost or if things go backwards, but let's work on some rotator cuff. Let's work on some non-provocative loaded. Let's progress. Let's learn how to do a Turkish get-up. Let's train with a shoulder that when it's pain-free clearly has the warranty to get after it. And you see me whenever you need to.